to discuss the complexity of our blood system in Pakistan. And for this, we have a very wonderful personality who is an kind of authority here in Pakistan, Professor NUZHAT MUSHAHID. A very quick introduction, although her work has takes some time to explain what she has done, but a very quick one, that she is not only a distinguished clinician, but also an academician and a national authority in transfusion medicine with over 36 years of distinguished service in Pakistan, military, as well as civil healthcare sectors. So Professor Nuzhat has done her fellowship from Edinburgh, as well as she has done her certificate in transfusion medicine from there too. She is the gold medalist of exceptional academic standing. She has done her, sorry, my apologies. She is the gold medalist of exceptional academic standing. She completed the international fellowship at St. Louis University Hospital, USA, and the North London Blood Transfusion Center, UK. Currently, she is serving as the consultant for national blood policy at Islamabad Transfusion Authority and Islamabad Health Authority, as a laboratory and a blood bank director at RIPA University, and as a CEO of P-firstsolutions Blood Center, Rawalpindi, a Category A+ licensed private blood center, as she founded after retirement. In addition, she is leading a project for setting up first source plasma center in the country for manufacturing of PGMPs, and which will be the first step towards the developing plasma economy, which is a very unique way of saying the plasma economy. It strikes this word to me. So I will, as you all know, or perhaps we have very little information, that almost Pakistan needs more than 5 million blood donations annually, but we are hardly reaching half of it, even less than half of it. So let's hear from Professor MUSHAHID what she's been doing and what is the future pathway for this.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Akhtar and APPNA MERIT and my distinguished colleagues and dear friends. It's just a profound honor to be presenting this presentation of mine today. I appreciate what APPNA has been doing for our beloved homeland, and I'm deeply grateful to this platform for considering me worthy to talk about this work. It's an opportunity to share that, as you will see, it has been much about the nation's health, and it has been about someone who quietly refused to give it up on it. So thank you so much. Let's move on to my next part of the slide, which is, before I go into detail, let me set out the arc what I'll cover today. We'll begin with some introduction, background, and context, because blood systems just don't fail in isolation. From there, I'll lay out the problem very clearly and honestly. Then I'll turn to the solution that exist and those that are possible. I'll talk about those who need to act, what needs to happen, and how to play. Because it's just not a government problem, it's a professional responsibility as well. I'll present the sparrow story, later on, a sparrow story, sort of an analogy of my contribution. We'll come to that in the end. So let's begin with the first part. I want to take you back not just to recent history, but to the foundational conditions that shaped where Pakistan blood system stands today. So what is the stake and why does it matter? Let me take you to, talk about some numbers. Pakistan collects an estimated 3.5 million blood donations every year. I say estimated deliberately because we have no formal national data. We are making decisions about a life-critical system that we haven't even accurately measured. A significant proportion are still not screened to international standards. And the consequence, about 12 to 13% of HCV infection in the countries are linked to unsafe blood transfusion. Pakistan holds the unenviable distinction of having the highest HCV prevalence in the world, after Egypt, which has since eliminated it. Thalassemia carrier rate in the country is average 5%, with over 100,000 thalassemia major patients requiring lifelong intensive transfusion support, diverting almost 100% of volunteer donor to this cause. And then they die in their teenage. And then there's the plasma. Pakistan imports $85 million worth of plasma-derived medicinal product every year through both formal and informal channel, because we produce zero ourselves, a country of 240 million people with massive unmet clinical need, importing life-saving medicine it could possibly produce at home. And finally, look at the mortality, maternal mortality, 154 per 100,000 live births. Pakistan's rate remains among the highest in the region. And 30% of those deaths are from postpartum hemorrhage, unavailability of blood in time. This is what is at stake. And if we want to talk about the urgency, let me take you through what's the urgency. The HIV and epidemic aid from 1981 to 2000 shows a detailed timeline tracking the epidemic from the first 5 cases in Los Angeles to, the blood supply being infected, the hemophiliacs, almost 12,000 contracted it, while the blood banks resisted the screening. Then there were, by 1985, new cases exceeded all prior, an 89% annual rise. And Rock Hudson was the first celebrity death when Reagan named aid only in 1987, 6 years later. And by 88 to 90, 100,000 deaths. And then finally the world starts reacting. And the WHO estimated that, 5 to 10 million cases are the carriers of HIV. And then you can see the lost, how Africa was lost to this epidemic. And by 2023, we had 40 million deaths globally, as per WHO. Now, this is the book. You all must have probably seen it, read it, published in 1987. It closes with the Rock Hudson death in 1985. The moment that finally forced the mainstream to acknowledge what has been happening for years. The verdict, as you can read here, was not ambiguous. AIDS did not just happen to America. It was allowed to happen. Pakistan's story of HIV and AIDS is a 4-phase timeline, starting from 1986 to present. Tracking Pakistan's HIV and AIDS response, as you can see, it was in 1987 that the first case was due to unsafe blood transfusion. And then National AIDS Control Program was established that was only diagnosis-based, no focus on prevention. And most of these were deported Gulf workers who were carrying HIV. There was no community strategy or surveillance system. Then we had in phase 2, starting from 2001, where the extended HIV and AIDS control program was the first national strategic program for that. The focus shifted to intravenous drug users, the sex workers, the truckers. And still you could see that the tragedies kept on happening. And third phase, we had 18th Amendment, the devaluation of health services, where the provinces were responsible for implementation. So the progress was stalled, coordination gap widened. And now what we are seeing is again the repeat of those tragedies. The Sargodha, the Larkana, and still Pakistan program for HCV elimination, for prevention as a strategy to the treatment as a preventive strategy, does not have any strategy for TTI prevention. So blood transfusion now accounts for almost 12% of the reported HIV transmissions annually. Now, let me take you through the specific history of blood transfusion reform in Pakistan, because there have been many attempts, genuine, well-funded attempts. At partition for 1947, Pakistan inherited just 4 blood banks. They were located in 4 provinces. There was no policy, no regulation, no framework. For the next 4 decades, the sector drifted. It was fragmented, unregulated, and largely invisible to the policymakers. The first legislative efforts came in 1990s to 2007. Provincial safety laws are passed. On paper, a framework existed, but in practice, the legislation was largely unenforced. Then came cooperation with Germany. Between 2008 to 2016, the GIZ, the development agency of government of German government, and its development bank KfW invested 15 million euros in Pakistan blood system in the first phase, and then second phase, another 10 million was invested. Total 18 regional blood centers were built and equipped in 2 phases. Blood transfusion program was separated from the AIDS control program in 2010. A governance body similar to National Technical Advisory Committee was mandated, but it was never formed. And then in 2023, the German partnership ended. The Safe Blood Transfusion Program, which was coordinating it across the provinces and center, the coordinator had already retired in 2019 and was never replaced. The Islamabad, the federal areas, a regional blood center became non-functional, although it never functioned optimally in any case. So 2025 marks another, I would say, a usual milestone, I would call, keeping in Pakistan history in perspective. The national blood policy for another 5 years has been approved by federal cabinet in 2025. National Technical Advisory Committee, which was mandated in that, has been constituted in December 25. However, DRAP has been designated as a regulator for plasma established first time in the policy and actually. Now the infrastructure exists. The question that matters now is whether this time we will be actually implementing it policy and somehow able to monitor it as well. So this is what the Germans' 25 million euro investment looks like. What was delivered was the program, the transfusion program was separated from AIDS control program. All provinces and areas enacted their blood transfusion acts. Blood transfusion authorities were established in all provinces as well as in Islamabad. And as I said, the 10 regional blood centers as well as 59 hospital blood banks were upgraded in first phase. And at least the facility for chemiluminescence screening was made available in all of the regional blood centers. And that is moving quite a big step for moving from the rapid devices screening to a chemiluminescence system. These regional blood centers were equipped with information management system as well. In phase 2, then further 8 more centers were opened, 30 more additional hospitals were renovated, and then all the required quality guideline, SOP training, curriculum, a lot of papers by Safe Blood Transfusion Program was produced with the help of consultants abroad. By now, some of the centers have been handed over in a private-public partnership. And we are proud to say that at least Indus Healthcare Network was managing 3 of these governmental public sector RBCs are actually doing a wonderful job, and they lead in all benchmarks. So the total capacity of these RBCs is around more than 0.6 million donations a year by 2022. So this captures the physical footprint of the 25 million euro investment. The regional blood centers distributed across Pakistan, from Karachi to the Gilgit, from Quetta to Peshawar, and from Muzaffarabad to Mirpur. And these were additional recommended ones, but they were not then made. I mean, it was the responsibility of government of Pakistan to actually further take up this sort of hub and spoke model all over Pakistan, covered those regions which were not covered by the German cooperation. Now, this slide captures a principle that sounds simple, but has been a single most violated principle in Pakistan blood system. The state is responsible for making the blood system, blood transfusion available to the population. The blood regulatory system has to be in place to actually look at this, that well-functioning, the one that is responsive and ensures the safety of blood through a hub and spoke model, where you have the regional blood centers who are responsible for collection, processing, and then they are the suppliers for hospital blood bank, where actually the patient samples and cross-matching and issuance is done. So sometimes in many countries, the state itself does not deliver the service directly. Sometimes this responsibility is taken up by credible organizations like NGOs, and then state very responsibly regulates the service. And they are able to mobilize the volunteer donors to take care of the first layer of the safety, and that is the volunteer donation. So this is what we call as a hub and spoke model. Okay, now we have seen the history, we have seen what was built, we have seen the principle that should govern the system. Now, let us be honest about what is not right. What follows in further slides is, it's not a criticism on its own, but it's a diagnosis. One cannot treat a condition without accurately naming it. And Pakistan blood system has been suffering from a set of very specific, very identifiable failures. Let's look at them squarely. Same investment, some 25 million euros. Now look at what it did not fix, because this list is just as important as the achievements I described previously. You can see that in public sector, which it targeted, hub and spoke model world over, proven efficacy and benefit, has not been implemented. Regional Blood Center Islamabad, not functional. It was supposed to be built for providing 50,000 blood products to at least Islamabad area. GB is also not functional. The Safe Blood Transfusion Program coordinator vacancy is empty, and no replacement has been done. In fact, this whole program is like now almost dead, and there's no alternate framework which has been created. There's imperfect national data collection to begin with and had been stopped entirely. Governance body that could have steered the implementation of the policy and has been mandated since 2008 never materialized. Our national target of 100% volunteer donors falls quite short since long. The blood establishment computer software is only implemented in RBCs, not at the hospital blood bank, and there's no national tracking system. There was no sustainability plan actually after German exit in 2023. And there's no plan to wean from overseas health assistance, which has propped up this program. About 0.3 to 0.4 million liters of plasma is either not made or is discarded annually. And there's no plan for surplus recovered plasma or to do about it. There's a regulatory fragmentation, serious regulatory capacity, and regulatory coordination issues. The private and NGO sector, which has over time become very dynamic and large, has not been integrated in the national blood system. There's a large number of donations still being tested by rapid devices of dubious efficacy. And on top of that, we have no true political will, and we do have misplaced priorities. Okay, I want to zoom out for a moment because the blood system does not exist in isolation. It sits within a much larger story of how Pakistan finances its health sector. And that story is urgently relevant to us. Pakistan receives an average of $5.2 billion in overseas development assistance every year. It represents, about 1.65% of the GDP. And of that, health-related overseas development assistance is about $1.5 billion each year. It's about 0.4% of total health expenditure. So I also want to name something that is happening right now. In 2025 and 2026, that changes the calculus entirely. The global overseas development assistance environment is contracting. USAID has been dramatically cut. The PEPFAR, which is the president's special initiative for HIV, is under threat. The global fund is under pressure. And Pakistan has been building its health infrastructure on a foundation that is being pulled away. It remains a present reality, and it demands an urgent answer to the question, which has been avoided for a decade, that how do we finance ourselves? As you can see, that the total expenditure in 2021 was about $11.6 billion. And out of these, 47% was out of pocket of the people. And the rest is this breakdown. This is a snapshot of what overseas development assistance has been funding in Pakistan. You can see listed here. This is the scale of financing and responsibility that diminishing overseas development assistance requires from our state. It reverses the gains that took decades to build, and signs are already there, like here. Okay, if I want to talk about data, because everything I have described so far, every failure I have named has its root in a failure of evidence and data. One cannot govern what one cannot measure. And Pakistan, for most of the part, cannot measure its blood system. As per WHO Global Database on Blood Safety Framework, these are the 7 types of data they require and which the countries are supposed to collect and submit to WHO. This is the slide is a reference, and I'm not going to read every cell of it table, but I do want you to understand what it represents and why it matters. What we are looking as a WHO Global Database Safety Framework, which is translated into actionable policy language on the right side. For each domain that was listed tells specifically what data we need to collect and what decisions the data would enable us. Now, let me take you through to the regulation, because without credible regulatory oversight, nothing else in the system holds. And the gap between where Pakistan stands and where it needs to be is quite stark. Start with the regulatory structuring. Internationally, there has been a logical transition to models like European Union substances of human origin and USA medical products of human origin, where regulatory refragmentation for biologicals of human origin has been regulated and brought under single framework. In Pakistan, we have at least 5 or more fragmented authorities: Blood Transfusion Authority, Healthcare Commission, this Human Organ Transplant Authority, Drug Regulatory Authority, which has been excluded from blood for so long, but it is essentially required. So there's no uniform mandate, no single accountable body. Pakistan Blood Transfusion Authorities even have no awareness of Global Benchmark Tool Plus framework. No blood transfusion authority has even developed regulation to be formally promulgated since the acts are in place since 2016 and 17. Pakistan Blood Transfusion Authority has no blood establishment GMP inspectorates. Recently, last month, DRAP has developed their Annexure 7A framework for plasma establishment based on the policy that is drafted in 2025 and has not yet been enforced. Internationally, 100% of licensed blood establishments with unique facility identification. We don't have any registry of blood establishments. No information management system is mandated. So internationally, a functional and advisory framework, including binding technical guidance in collaboration with WHO and PICS, are practiced uniformly and used by the regulator. We do have standards which are existing since, under the Safe Blood Transfusion Program, but they were never enforced. And the Safe Blood Transfusion website is offline since 2019. Without credible regulatory maturity, Pakistan cannot export plasma. It cannot attract fractionators, and it cannot earn any international trust for its blood system. That's the bottom line. Now, this slide gets to the heart of one of the most consequential and most misunderstood regulatory problem in Pakistan blood system. And it is rooted in a constitutional misinterpretation that has cost us years. Here is the correct interpretation. Blood and blood components are biological drugs. Plasma is a drug substance. In other words, active pharmacological ingredient or API under the National Drug Act and Drug Regulation, which precedes the Blood Transfusion Acts and Regulation. The Therapeutic Goods Regulation is explicitly a federal subject. DRAP's mandate covers biological drugs. The 18th Amendment devolved health services. It did not and could not devolve the regulation of drugs and therapeutic goods. That remains a federal subject. So this is not a technicality. This distinction is the legal foundation for everything that follows. Because if the blood is drug, which it is, then DRAP is the regulator. And DRAP as a regulator means a single, accountable, nationally consistent licensing and oversight authority. But what has happened is probably it's a very uphill task to somehow correct what has been a misstep from the blood transfusion angle. Okay, we have talked about data as a policy and governance imperative. Now let me bring it down to the operational level. Because the absence of a functional, harmonized, computer-based management information system is not just a planning problem, it's a patient safety problem. So blood establishment computer software is not an option in a modern blood services. It is the central nervous system of the entire operations. It generates the data that managers, the regulators, and policymakers need to make decisions on. So the work here by the consultants under GIC had produced marvelous, policy position and policy papers and guidance documents. This slide just shows the identification uniformly that is world over implemented. That's just what the International Society of Blood Transfusion 128 and traceability system mandates. This slide just bring us to two dimensions that often are overlooked in discussions about blood policy. To me, this is one of the most important one. The first layer of the safety. The volunteer blood donor organizations that the lifeblood of a national blood system. Pakistan has over 1,000 active blood donor organizations nationwide. That's quite an extraordinary civic asset, a network of motivated, altruistic, reachable people who have built whom we can build the voluntary donation into a community practice. But this works largely without the government support or framework. So what sort of NGOs what sort of blood donor organizations we have? Either they are NGOs built out of thalassemia and hemophilia cares, or they are university-based blood donor organizations, or their community and faith-based networks. Then over the time, a lot of digital presence of blood donor organizations are also there. But why they have not been effective? Still, we are having about 22%, 82% of our donations are family and replacement and directed donations. Let's look at the reason. I think one of the big reason is what I have come after setting my, blood bank in a private sector, is that there's a rescue culture versus a scheduled supply. This is built around emergency response. These blood donor organizations are not linked to blood centers and hospital blood banks. They're not even visible to any regulator. So that becomes a donor safety issue as well. Of course, there are cultural belief, this sectarian identity as an organizing principle is there. And there is a justified distrust of public blood banks. And government-owned blood banks score very low on the patient safety versus the NGO and private banks. And because of these fragmentation, we don't have a national deferral registries or system, which should be linked with their national identification cards. Okay, here is, a snapshot of both the albumin domestic needs present, how much is being imported through formal and informal sectors. It's about 5.3 million grams of albumin, and the informal sector covers this much. So the total, we import annually about 6.3 million grams of albumin. And if you translate this into the volume of plasma that we would need to actually generate this much of albumin, this equates to about 0.3 million liters of plasma, which we already have in our, in the form of recovered plasma, which is not being utilized. And if you look at based on the population, the total domestic demand or need of the albumin, that's listed here. And how much it equates in terms of the plasma volume, about 2.1 million liters of plasma. That's how much if you want to meet the total 100% demand of the country for albumin. And exactly the same way, this is the IVIG, which is being promoted, which is being imported formally as well as informally. And that's the sort of plasma volume which would replace the existing demand at least. But of course, in order to meet the total demand of the country, we'd probably need more than 4 million liters of plasma. This is a summary, but just want to bring home the point that everything we just seen about the plasma. The clear statement of the opportunities here. Pakistan has the donors, at least the replacement one. That's the source of recovered plasma. It has the clinical need. This is the discarded raw material. Now we do have a policy framework. What we need is the will and the investment to turn this unrealized opportunity into a reality. Okay, now let me hold a mirror to my own professional society. Everyone is familiar to what professional societies in a functional healthcare and developed countries would do. Here's this reflection we could not do over the time. We never produced any clinical guideline. We were on the periphery of this activity, whole of it. There's no postgraduate fellowship in transfusion. It's just a small part of existing FCPS hematology. There's no, society-led or university-led national blood program on the safety. So we remain aloof to whatever is happening in the transfusion landscape. And similarly, the patient blood management never advocated with sister societies or anywhere with other clinicians. So the question is not just what government failed to do, it is what we professionals have collectively failed to demand as well. So let me bring the problem section to close by this summary statement that Pakistan built the infrastructure with overseas assistance. It could not build the universal, well-tested model of hub and spoke model, covering the regulatory capacity, oversight, the political will, and sustainability. So, okay. Now, we have named the gaps in the infrastructure, in regulation, in data, in political will, in professional accountability. Now, let me talk about the solutions. The transition from aid-dependent health development to domestically financed, domestically owned, domestically accountable health system is not optional. It is the only path to sustainability. For the blood system specifically, this means something very concrete. The plasma economy is not just a public health solution. It's a domestic financing solution as well, and it has been spelled out in the policy as well this time. A functional, regulated, internationally compliant plasma industry generates revenue. It can substitute imports. It creates skilled employment. It can build institutional capacity that serves the entire health system. The federal cabinet approved the national blood policy last year, September. There are 15 comprehensive objectives. The most detailed, most ambitious, as a very prescriptive document, an internationally aligned blood policy that has ever been produced. I've just listed and clusters summarized here. I'll later share the full national blood policy with APPNA so that anyone interested can read all these in detail. The way forward is not complicated. It does not require new ideas or new frameworks. It just requires implementation, disciplined, accountable, sustained implementation, or what we already now know that it works. So I've listed the priorities, which are again also listed in the national blood policy. That foremost, we create a steering committee so that they work on all the aspects as a think tank. Build the regulatory capacity, implement through a hub and spoke model for at least doing testing at the basic CLIA level of TTI screening, build a plasma economy, develop human capital, and activate the voluntary blood donation with whatever it takes. Every solution I've described, every priority, every framework, every policy objective ultimately depends on one thing: the quality of people appointed to lead it. So one good governance initiative that can actually make a lot of difference is if there's the right person for the right job, with proven integrity and character, capacity to view the larger picture, connect the dots, and have out-of-box solutions. And those persons be provided authority, resources, and so that they can steer it, implement it nationally across all provinces. So National Steering Committee, it's the broadest mandate ever given to any blood advisory body in the Pakistan. It's a permanent think tank which has been proposed, not one off-time committee. Membership criteria requires integrity. They'll be not remunerated. Their activities might be. And they are designed to function, hopefully, beyond electoral cycles. And they should be considered very seriously by all the relevant implementation limbs of the country in any sphere which are relevant to blood transfusion. So it can become equivalent to one of those bodies which is well known world over. So we talked earlier about 7 WHO data domains as a diagnostic framework, a way of understanding where Pakistan blind spots are. So here's the construction blueprint, because building the data architecture for a national blood system is not a software project. It's not just a reporting exercise. It is the infrastructure. It must be treated, funded, and governed as an infrastructure. So what does this international reporting have to do with fixing the blood system? Well, this study explains that's the sort of help that the planning and monitoring and advocacy and resource mobilization would need. So all those data points are going to be the inputs for those plannings. Okay, we described in previous slide the constitutional misinterpretation that fragmented blood regulation across 5 or more authorities has confused the investors, has frustrated the international partners. I've witnessed many of them, and they have left the system without a single accountable regulator. So how we can resolve is probably a vision, because practically it will take a lot of political will and a lot of time to actually come to that vision, which people have decided world over. At least I gave you example of Europe and America, where they're turning to regulating all substances of human origin under one body. So our vision is also that we should have a uniform regulatory model, as I said, taking cues from what those people have practiced and have promoted. I'm not advocate of somebody who just would keep on duplicating and replicating and just copying whatever is happening on there. Anything which is sensible, anything which is applicable to our context, anything which is good for the system that we are designing, that should be adopted and adapted. Okay, we would, of course, the regulatory capacity has to be built. There's a wonderful WHO guidance, which is called Global Benchmark Tool Plus, for asking the regulators to build their capacity. That's a roadmap. So it has 4 maturity levels they advocate, in which these are those parameters, and these are the maturity levels where just few elements exist, that it evolves with a department program, complete program. Then it becomes stable and integrated, and then you have the advanced program. So fortunately, our drug regulator is at maturity level 2, and it is expected to reach maturity level 3 by next year. So that's quite a satisfying progress that they have made, and that is going to help our export of plasma and fractionation, because for first time, their role has been defined in this national blood policy. So that could be the roadmap to attain the WHO Global Benchmark Tool Plus by our blood transfusion regulatory authorities. We can phase these out, starting with the foundation, institutional development program, do the needful, document everything, have the standards and the guidelines, then go from maturity level 2 to 3, and finally consolidate the targets and achieve the maturity within 5 years. That I tell you would be a game changer. It's a huge thing if we can target that and work towards that and achieve that. Now coming to the special interest group I've proposed last month with our society. So the aim is to form a special interest group within PSH, so that we can advocate with the government, we can engage the regulator, we can work towards the standards and good practice guidelines, we can enhance the capacity through training. Then we can even have something like American Association of Blood Bank, where we can have a accreditation program from the professional society, which can go a long way to actually capacity build and guide the actually blood establishments. Okay, now coming to the final story, the legacy of one of my great teachers. He used to tell us that, there was once a sparrow who was lying like this, and somebody passed by and asked her, "What are you doing?" She said, "You haven't heard that the sky was going to fall, and I'm trying to prevent from falling. I'm supporting it." So that is a sort of story that sometimes when I get involved in that, I feel that if you have so many sparrows doing the same thing, probably we can hold the sky from falling. Okay. So this sparrow, what we have been doing is I set up my own private blood center, and the aim was to actually centralize the screening through the best of the technologies, which is nucleic acid amplification. So set up a system, use technology, train people, and become accountable. That did not work because of the two reasons that, number one, the regulator was not demanding it. And secondly, the customer was not demanding either. But that does not mean that I gave it up. I just took another course and kept working on that. One of the things that I worked on, as I said, that we needed to develop the brain system of all of the blood banking. For that, I raised my own IT team, and we developed a smart blood bank and management system, which is compliant with the International Consortium for Commonality in Blood Bank Standards. And we advocate that it's available for regulators, for blood establishment, for plasma establishment, anyone who wants to use it. We got certified. We got the facility number in 2019 and 20, and we're happy we are using it. Okay, so that was where I contributed in big way, the policy writing. It took us 2 years to actually get to obtain the consensus of the provinces, and finally it was approved last year by the federal cabinet. As I said, it's extremely prescriptive. I'm going to share it with you. So what does this led to? For the first time, we were able to clearly spell out what we need to do at regulatory level in order to make our plasma acceptable to fractionator, who would look at what type of regulation is present. So fortunately, after passing of the policy, I was able to get engaged with the DRAP, and I must appreciate that they also worked hard, and we were able to put in the quality management system policy for plasma establishments, as well as the mechanism of export. Some of them already existed for biological, and some were put in place in January 2026. So that's the one which is now implemented. Of course, we needed to build capacity if somebody wants to set up a source plasma center and blood banking. So for that, I had a understanding with our Health Services Academy in Federal, Dr. Shahzad. I really appreciate and thank him. He has been very forthcoming, very progressive person. So we had understanding that we can have a certification program, diploma programs for blood banking, as well as for apheresis technicians. And finally, there's a big player. They want to invest in plasma economy. They've started their work. I'm there advising them on the first source plasma project of the country. And hopefully, we should be able to make progress by end of this year. A center should be completed, and then we should be sending our plasma for PDMPs to hopefully China. So one of the steps we took was to have an assessment of will we be able to mobilize the donors for this cause? And we carried out the studies, and we were happy to receive very good response from our donors, and this was very encouraging. So that's the sort of thing on the SCAP study, the final reflections that we compiled, and the more to it, of course. And many people ask me that why I don't give up and just narrate Allama Iqbal's quote that inspires me all the time, which is "Mujhe hai hukm azan, la ilaha illallah." With this, I thank you very much for your very patient listening. And any questions are welcome. Thank you.
Thank you very much, Professor NUZHAT. It's really thought-provoking, and it made you cry really, because that is the situation. We have evolved into many fields like therapeutics, like diagnostics, but where we are in transfusion medicine. Unfortunately, there is a little known about this thing to the physician as such. And so is the case with the regulator and the policymaker. And, it was a big, and I was also privy to that thing which was happening when the KfW and the German government, they tried, and I think that was the most meaningful intervention ever had. And we are so unlucky that we could not took full advantage of this thing. And then, it is a in between. And as you mentioned, whatever started, it is in between. And you are privy to each and every step. And you are really devoted person and a selfless approach to develop the policy and whatnot really. And am very, very honest. I have yet to see such type of presentation ever in the APPNA platform, which is actually quite reflective of the country's situation. And I think it is one of the benchmark presentation we ever had, and it will be available. I really appreciate, but it's so true that आप अपने हिस्से का दिया जलाती रहीं, जब भी मौका मिला और आज़ान देती रहीं. No 2 points. And with this, I will hand it over to Dr. Akhtar Hamid. If he has any comment, question, or anything. I requested any participant if there is any question, but so far they just say thank you very much. It's a wonderful presentation and no real question. But if there's no question from the participant, I may have.
I have questions.
Yes, go ahead, Dr. Akhtar.
I have questions. Okay. First of all, thank you, Professor. It was really eye-opening kind of presentation. You walked us through the partition until today. It appears that we had few opportunities, but we are not able to capture it. And then there was no obvious will or political will, or maybe the people in the government didn't have that much of insight that how important this it is. Even internationally, after the death of Rockhurst and the President Reagan at the time, and they really had a little bit of shaken, and the world started to know about it. It reminds me that particular news which flashed when you presented it. Only thing I'm thinking is in Pakistan, there are different people working in silos. In Karachi, Fatmi, then other blood bank for thalassemia center, and also Indus, and every hospital has it. I was going through some standardization of blood bank, because you need to have a central, as a WHO is saying, that you need to have a central authority or regulatory authority, and then you know how to collect the blood and how to process the screening, and then how to transfuse to the patient. What minimum standard, which is set by the WHO, because they do have these levels or processing thing. So where we are at, because I'm also reading about American Association of Blood Bank, which is one of the gold standard certification or accreditation. And I think one of our hospitals, I think Indus does have it, the transfusion system. Not even in India, hardly any, or maybe one or two, they possess this. So where do you see that, what are the areas? You mentioned about the draft, we have started something last year, but it's a long way to go.
Certainly, there's a systematic way of approaching this thing, and the one basic thing is to have minimum standards and good practice guidelines for that. What we have done, and what I'm advocating, and what DRAP has also adopted is we don't want to reinvent the wheel. The standards are there. And for those which are really applicable to ours are those guidelines which developed by WHO, and the other very good one are the PICS, the Pharmacological Inspection Coordination Scheme, which is recognized world over. So that is what we are trying to do. Instead of producing your own, just adopt and adapt those. And if we are able to adopt and adapt those and do the work quickly and then implement it, it's the implementation which is the most important key thing that is missing. So what the DRAP has done for at least for the plasma establishment is they have put in their law that whatever PICS standards and guidelines are, whatever WHO guidelines are, whatever any stringent regulatory authority guidelines and standards are, we are going to adopt it. So that makes it very simple for us. So if our blood transfusion authorities adopts these PICS guidelines and standards, we are good to go. We just have to see how it, in a phase-wise manner, we ask our blood establishment to come to a minimum standard. The first thing is at least to know where we are and have a model developed in our brain, have a consensus on that. Because, our fragmentation, the reason for fragmentation is that we are working in 4 sectors. We have public sector, the biggest one. We have now big NGO and private sector and a military sector. So it's not that the private sector and NGO sector will be funded by the government, but then they have to be brought within a framework of a national blood system in some way, so that we stick to the principle of availability, safety, accessibility, and quality. So that is the key, where what we have tried at the national level in this policy is to put a steering committee of experts, the regulators, and all the stakeholders there, so that we don't work in silos. We sit together, chalk out a plan, guide people, produce the documents, and then try our best advocate with the government to provide resources to implement it.
Like we have a model, truly said, because we don't need to initiate or you need to invent a wheel. We can just use whatever the standards are there, and we change it into or adapt according to Pakistan context. And that would be an easy thing to do as compared to start everything from the scratch. Now, there are some blood banks, like there are also ISO standards like Dow University or some Imperial Blood Bank. But the PICS and the WHO, I think that makes sense, that which can have the standards and we can just follow, and then we can start, going up and up if possible. My question is, that a health system has a primary care, secondary care, and then tertiary care. And you mentioned about the hub and spoke system. Do we have something initiated in a way that we can start replicating those hub and spoke system across the country?
We have,
in terms of blood transfusion?
We have, luckily, that's a success part of it. The German government funded this hub and spoke model. The challenge that remained was the day after. The government had to take the responsibility of not only maintaining this center, either by running itself or outsource it to someone. And fortunately, in Punjab, at least 2, and in Sindh, 3 of them were outsourced in a public-private partnership. And they proved to be a success. And since Indus has more experience, I would say, and kudos to them and credit to them, that they were the first one who worked very hard on the hub and spoke model. And they were able to do it in Multan. They were able to do it in Rawalpindi. There's still, there's some way to go, but they have at least proven that can be done by the private partnership. And now they are doing in Jamshoro, and they have made quite a good progress. Rest, all of the public sector has to follow that suit. Now the governments have to decide that so far the data has come up, a very sketchy one. I said, that's an unfortunate thing that unless we have a data, we can only, presume and assume things, that that has the government been able to do a good job as a private-public partnership? No, it has not been. So that means that we should probably should be giving it in a public-private partnership, all of the public sector ones. And then about the rest of the sector, with the private sector, yes, it has to be regulated because they fund themselves, but regulated in a way, you sort of encourage them, move them in a direction that the private sector and NGO sector also evolves in a hub and spoke model. So that will depend upon the type of regulation that is written by a province, for which I am advocating. And for one of the reasons that I'm traveling here is I'm trying on my own capacity to, impart that how we can do it. If we are able to put a regulation in place, we coax those people towards a hub and spoke model, this is going to benefit all of them.
Thank you. So with that, I know it's very interesting, and as you know, this field looks like still in their infantile stages. We will definitely get more presentation from you in future to see how we are progressing. I would like to thank you from the platform of APPNA MERIT, and wish you luck with your journey, and hopefully Pakistan will be able to sustain some sort of policy and regulatory thing on the blood transfusion. Also, I would like to thank you, our unsung hero, Waleed, who without him we would not be able to present this presentation. And thank you, Dr. Zaid, for being here, and you are like you have an ocean of wisdom about a lot of things, and if I let you speak, you keep talking on it as well. So thank you all, and our participants across the globe. Perhaps we don't need to mention any names, but thank you very much. We will we'll connect again, inshallah, next month with another amazing topic. Thank you.
Thank you so much. It's been a privilege to talk to this forum. Thank you, Doctor.
Sure. Thank you.